Okay, good evening and welcome to the program Mother and Child Clinic on your darling station, Unizik 94.1 FM. We are here again. This program comes your way every Tuesday by 4 p.m. But for some technical reasons, we've not been regular. But be rest assured that we are back with a bang. My name is Chigozie Chukwuleta. And in this program, we discuss health issues that are particular to women and children. So whenever you are, wherever you are, please get close to your radio set, as today we have two very important health issues to discuss. Our doctors this week looked at fibroids in women and neonatal jaundice in newborn. While Dr. Joseph Ikechebelo, the Deputy Vice Chancellor Admin, Nnamdi University, and consultant gynecologist, will treat fibroids, Dr. Wilson Igwe, a consultant pediatrician and child neurologist, Nnamdi University Teaching Hospital, will handle neonatal jaundice. You may have fibroids, or a friend, or a family member. Also, you may have encountered a child who had neonatal jaundice and died, disfigured, or survived. Today, this program will prepare you on how best to handle any of such issues. Please stay tuned and don't touch that dial as we go for a short musical break.
We have a mandate to make you smile, and that's what we're here for. It's Unizik 94.1 FM.
Mother, you are my soul. You are my soul.
The bond between a mother and child is one that can't be unwound. A lot of times, people don't get it, but the truth remains, it's there. Join Chigozie Chukwuleta every Tuesday by 4 p.m. as she takes you on an interesting expose on the program Mother and Child Clinic. Mother and Child Clinic, connecting all the dots.
Oh yes, I am a child. Mother and child. Mother, you are my soul. You are my soul.
The bond between a mother and child is one that can't be unwound. A lot of times, people don't get it, but the truth remains, it's there. Join Chigozie Chukwuleta every Tuesday by 4 p.m. as she takes you on an interesting expose on the program Mother and Child Clinic. Mother and Child Clinic, connecting all the dots.
Oh yes, I am a child. Mother and child. Okay, welcome back. I know you really you are ready for what we are going to talk about today. Fibroid and neonatal jaundice. So let us first listen to Dr. Joseph Ikechebelo as he treats the issue of fibroids.
Yeah, thank you, and today welcome all my listeners, and we are talking about fertility challenges, particularly what we call uterine factor in infertility. And the uterine factor we will discuss today is uterine fibroids. Uterine fibroids is a popular condition. Almost everybody knows it. It has acquired different names, even in our Igbo language. Na ukwu Igbo a na-akpọ ya ajị enyi, na-akpọkwa ya mkpume afọ. So you can now see that even in the days of our fathers and in the traditional society, uterine fibroid was already recognized as a blemish on the womb of a woman that may result in infertility, inability to have a child or to conceive and have a pregnancy. Today we will talk about what are the causes of this uterine fibroid. If this uterine fibroid is this important to us, what are the causes? So if we talk about the causes of this uterine fibroid, the first one we'll mention is that uterine fibroid is caused by, okay, let me put it this way, that it comes as a result of abnormal growth of the muscle of the womb. This womb you see in pregnancy enlarges, and suddenly the baby is delivered, it shrinks back again to its normal size, involution. So it is filled with muscles, and that's why it can enlarge and it can return back to normal again, what we call hyperplasia and even multiplication of the cells. So these muscles of the womb, an abnormal growth of that muscle is what results to a fibroid. So each particular fibroid mass is a muscle in the womb that has turned into and started developing abnormally. So that is uterine fibroid. Again, this uterine fibroid, when we discuss the causes, is actually supported by a particular hormone in the body system. And this hormone is called estrogen. Estrogen is what supports the growth of the uterine fibroid. This is where it becomes tricky, because this same estrogen is the same hormone that every woman requires to have a monthly cycle. So any woman that is menstruating and having her monthly cycle has adequate amount of this estrogen, and it's this estrogen also that also supports the growth of the fibroid. You can see how the devil is a bad devil. He has attached this condition to something that is normal and is important in the body system. So we can't do without estrogen in a woman, and the fibroid cannot do without estrogen. It requires this estrogen to grow and to continue to feed itself and get to the size it's getting. That is why we don't have uterine fibroids in a woman, in a girl, before her menstruation starts. So a girl that has not started menstruating will not have a fibroid. And when a woman stops menstruating at what we call menopause, she cannot develop a new fibroid. It is only the ones that have been in existence that will be there. And even those ones that have been in existence will start shrinking in size. So that's why we need to know about this all-important estrogen hormone. So the causes will be one. From the preambles I've established, we have found out that uterine fibroid is more common in the black race. So racial distribution is more common in the blacks. I don't know, maybe the blacks elaborate more estrogen or other things. Some people have also attributed it to the environment and dieting. But this is what we know about the cause of the uterine fibroid. Okay, they also know that it could also is more common in women who have delayed childbearing. Those who have delayed childbearing. Okay, so nulliparity, prolonged nulliparity. It is considered that uterine fibroid is a compensation for a womb that has not carried a baby. So it decides to carry something else, and what it can carry at that point in time is uterine fibroid. So when there is delayed childbearing, and that's why it's important when a woman gets to age of marriage to get married and start having her children, so the fibroid will not come as a replacement for not having children. It's also known that it is more common in certain geographical areas where certain foods are there, particularly these things that nutritional, let me use the word nutritional now, nutritional and environmental, and it's been shown that there are some foods that are elaborate more estrogens, particularly in this western belt and other belts where you have a lot of multiple pregnancies and these things taking place. So these are the things that make it more prevalent. So is there any other factor that's associated with it? People have also considered whether there are certain infections that can trigger the growth of fibroid, particularly sexually transmitted infections and human what is it called, the human papilloma virus and other few infections and everything that can trigger this. Studies are still ongoing in these areas to confirm exactly how and why. So that's about the cause of this fibroid. How will somebody know that he has fibroid? You are there, you are a young girl, you are a lady, you are a woman. How do you know you have fibroid? So we are talking about the clinical manifestations, signs and symptoms. Let me start from the symptoms. The symptoms, one, if menstruation, take your menstruation. I've told you that this fibroid is linked to the menstrual cycle. So heavy menstruation could be a sign that, oh, you may have fibroid. Oh. So that's number one, heavy bleeding, heavy vaginal bleeding, heavy menstrual flow. Number two, we talk about swelling in the lower abdomen. Swelling in the lower abdomen, okay? So because fibroid is like a mass, it's a solid thing that grows. So suddenly you start feeling that something is growing out of your womb, like if your pregnancy is coming up. So it is actually that womb, as the fibroid is enlarging on it, the womb is enlarging. And so it becomes, you cannot feel it on your lower tummy, and from your lower tummy it continues to grow up and grow up and grow up. So abdominal swelling is also another way you can know you have fibroid. The third one is pain, because this is growing and stretching the structures. Somebody can feel pain, lower abdominal pain, and when you feel this lower abdominal pain, I've given you three key things that will tell us that it's fibroid. The lower abdominal swelling, the mass on the lower abdomen swelling, the pain, and the heavy menstrual flow. These are three cardinal signs. The fourth one is infertility. If the woman has happened to get married and she's not been able to conceive, we can say the fibroid is causing this fertility challenge. So these are the signs, things you will see, or symptoms that you will witness, and the woman will know, yeah, it could be fibroid I'm talking about. The person needs further investigations to know. Of course, if we do an examination of the woman, the easiest thing we can find is this lower abdominal swelling, or that the uterus is bigger than the size it ought to be, and that tells us that there is issue with the womb there. So having talked about the clinical features, which is the signs and symptoms, the next thing to discuss is investigations. What can you do to find out exactly what I'm having is a fibroid? So we talk about investigations. What test we can do to find out that this is fibroid. I must say that the gold standard, that the commonest test available now that can actually clinch a uterine fibroid and tell you that you have uterine fibroid is ultrasound. Others call it scan. Okay, so whichever way you represent it, ultrasound or scan, it shows you clearly in an image that there is something inside the womb, which could be uterine fibroid. And remember, it is important that I describe it now that this fibroid can be in any part of the womb. Let me explain those parts. The womb itself has three layers that we normally think of. One is the outer covering we call serosa. Two is the muscle structure, which is in the middle, the muscles of the womb. And number three is the inner lining, which is what we consider to be the endometrium. That is the one that causes the monthly cycle or the monthly bleeding. So upon these three layers, fibroid can be on any of these three layers, because it's talking about the muscle. The muscle can, every fibroid starts from the muscle, but it can grow inside the uterine cavity, and then we call it submucous fibroid. It can remain in the muscle, and we call it intramural fibroid. It can push outside the wall of the womb, and we call it subserosal fibroid. And when it gets attached to the womb by a stalk, we call it pedunculated. And when this peduncle is completely detaches from the womb, we now call it parasitic fibroid. So these are the ways our terminologies go. So ultrasound will also tell you whether it is subserous, whether it is intramural, whether it is submucous, whether it's pedunculated. These locations have effect on the what the fibroid causes. Okay. So other tests that can be done to know whether this is fibroid, we can also do CT scan of the abdomen or MRI of the abdomen. And when that is done, if there is uterine fibroid there, it will show. And of course, other tests that we now do, these are the 2 or 3 tests: ultrasound, CT scan, and MRI. These are the tests that can clinch that this is fibroid. Other tests that we will do for somebody who has uterine fibroid is tests that we do for the treatment of the fibroid. If I want to go ahead to treat this fibroid, there are some tests I will expect the patient to go through. Like the patient has to check your blood level because you're bleeding and you're having heavy menstruation. Blood level may be low. Person will have to check the liver function test, the kidney function test, because you're obviously going to have an operation. We need to know that your body system is working fine. The person is meant to also assess the urine and to know whether there is sugar or glucose in the urine. These things are other tests that we can conduct, even chest X-ray. And if you want to also know whether there is affecting fertility, then that's when there is need to do HAG, hysterosalpingogram, or laparoscopy and dye test. These tests will give you all that you are requiring. So that's test. I'm sure you're waiting for me to talk about the treatment. So I've come to the key aspect. Can this fibroid be treated? What do I do if I find out that I'm having uterine fibroid? Let me also say that even though we have mentioned the symptoms of uterine fibroid, we can say that greater than 50% of people, of women who have uterine fibroid, will have no symptom. So they will have no symptom, no sign. So they won't even know they have fibroid. The fibroid is only found out if she's asked to do a scan for any other reason. Suddenly, the scan will pick up the fibroid. So in more than 50% is asymptomatic. So, but when it becomes symptomatic, what do you do? So for us, treatment of uterine fibroid is when that uterine fibroid is symptomatic. When it's asymptomatic, it's not causing any problem. Leave it there. You can get pregnant and have your children or have your babies even while the fibroid is there because it's not causing anything. But when it becomes symptomatic, manifesting as heavy menses, pain, bleeding, or infertility, it means that this has to be addressed and it has to be treated. So I'll mention those treatments. We have medical and surgical treatment. Medical and surgical treatment. Let me start with the surgical because surgical treatment is the hallmark of the treatment of uterine fibroid. Surgical treatment is the mainstay. There are 2 types of surgeries we can do for a woman who has uterine fibroid. One is the one we call myomectomy. Myomectomy is simply a surgery to remove the fibroid. Somebody will ask me, why am I removing the fibroid? Sure, you say that somebody can carry fibroid and get pregnant. Somebody can do this. Yes, but we have said when the fibroid has started causing problem, it's giving you abdominal swelling, it's giving you pains, it's giving you heavy bleeding, or your inability to conceive is already there. So it means the person will have to do surgery to remove the fibroid. I must emphasize now, surgery to remove the fibroid, very, very important and very critical. This is the hallmark of the treatment of uterine fibroid. And we usually say colloquially, you kill the fibroid before the fibroid kills you. Because the fibroid has come. The Bible says that every evil cometh, or the evil one cometh, but to kill, to steal, and to destroy. So this is the same way fibroid has come. Fibroid came to kill the womb, to destroy the womb, and to steal your child away. So if that is the case, you need to take care of this fibroid so you can have your freedom. And so that's where surgical treatment comes in, and you do a fibroid operation, remove the fibroid, and the woman will be free. So that's myomectomy. I'll still come back later to talk about the challenges of this, but that's myomectomy. Myomectomy is simply a surgery to remove uterine fibroid, period. And that's what myomectomy is. That's where she will also develop other what do I call it? Other treatments. One, we have talked about myomectomy to remove the fibroid. The next one is hysterectomy. Hysterectomy is now the surgery to remove the whole womb. It can be subtotal, where you remove part of the womb. It can be total, where you remove the whole womb. And I've just put it here that fibroid may be a reason to remove the womb. And this happens in women who have completed their families. You have finished having children, and suddenly this fibroid is there because you're still young and you're still growing. Fibroid comes up and everything. So you have two options: either to continue and deliver the baby, or to remove it, or to remove the whole womb, and that is it. So this is hysterectomy. Is there any other surgical treatment for this uterine fibroid? Myomectomy and hysterectomy. These are the two key ones. The other ones will be the technology to use. If we are doing fibroid operation, we normally do it open, or even the hysterectomy is done open. Open means I will cut open the belly and take care of the fibroid of the womb. But today we have a technology that all of us are clamoring for, and we are already a few of us in the country who have these skills and who are running with it. And that is to say, we can actually use the microscopic approach, which is the laparoscopy surgery, using the technology of telescopes and shooting it on the board, and everybody sees it, and then you operate. So that's one good area for training. So myomectomy and hysterectomy. Myomectomy and hysterectomy. Okay, yes, for surgical treatment of the uterine fibroid. The next in the treatment of the uterine fibroid is medical treatment. But before I mention the medical treatment, I was trying to clarify on the method of this operation. We talked about the normal method and then this specialized method we call laparoscopic surgery. Either laparoscopy or hysteroscopy, we can actually use it to remove the fibroids. No cutting at all. Just make small holes on the womb and use it on the abdomen and pass some instruments and use it to remove the fibroid. It's a beautiful sight to behold, but it's quite expensive. And so that is it. Yeah. Then the medical treatment. Now the medical treatment becomes useful if for one purpose or the other you cannot do operation. I have said that operation to remove the fibroid is our hallmark. That is the main thing. That's the standard of care that the person will have. So if you don't want to do surgery, let me put it that way. That's why we talk about medical treatment. For somebody who doesn't want to do the surgery, or for somebody, the condition of that patient, the patient cannot withstand the surgery. So you don't want to just take the person to surgery and the person dies in the surgery and everything, and that ends it, and the story will be out there that is because of fibroid. No. So what we say is where the person cannot have the surgery, then the alternative is to do medical treatment. One such medical treatment is medical treatment. Okay, let me give you first the principle of the medical treatment. We mentioned that estrogen, that's where the estrogen becomes important again. Estrogen is a key hormone supporting the growth of the fibroid. So it means that if you can withdraw estrogen from the system, the fibroid will not grow again and the fibroid will start shrinking. That's how we talk about shrinking of fibroids or reducing the size of the fibroid and everything. But then when you remove the estrogen, the woman won't also have a menstrual flow. So it means that the treatment of medical treatment of myomectomy is actually to create artificial menopause. Okay, so we call those drugs, we actually have gonadotropin releasing hormone analogs. Okay, so when you give these medications, they cause what is called downregulation from a burnout, and there won't be enough estrogen in the system again, so such fibroids will start shrinking. And this is very important. So that's one of the treatments and the key aspect of the treatment. Medications. We'll give you the name of medications later on. And then we have what a new technology that's come out that is called uterine artery embolization. Blood supply to this womb is coming from the uterine artery. So you can actually block the uterine artery, so blood flow doesn't get to the uterus as much as possible. It denies the fibroids their nutritional supply, and so they will start shrinking in size. So cut off the blood supply. So that's one. The other final one is a new technology, high flow ultrasonography. They are using high frequency waves to hit the fibroids and cause and denature the fibroids or the proteins or structures that are there, so that these structures do not continue to multiply. These are things about the medical treatment. So we mentioned the medical treatment, mentioned the surgical treatment. Finally, let me say prevention of this uterine fibroid is marry on time. Marry when you're supposed to marry, so you don't get the fibroids and everything. Start having your children on time while you're still young. If you look at our mothers and those who lived in the 60s, 50s, and 40s, if they marry early, sometimes they even marry before they have their first menstrual flow, so that they start multiplying in their husband's house and everything. And of course, you finish these things on time, and fibroid will not pay you a visit. So it's very important. Is there anything I'm omitting now in issues concerning uterine fibroid? Any other thing will be, if you have questions, you ask your questions. I will have the time to answer all your questions. And I must say, God bless you as you continue with your training. Thank you.
Mother and child, mother and child, mother and child, mother and child, mother and child.
Okay, you've heard it all. You know, our doctor today had been able to tell you what is fibroid, causes, what to do, and all that. Now, before the end of the program, I will give you a phone number to reach out to if you have any question. Now, let's listen to Dr. Wilson Igwe on neonatal jaundice. That's another killer disease that most parents don't know how to handle. So let's listen to the consultant pediatrician from Nnamdi Azikiwe University Teaching Hospital.
Good afternoon, listeners. Today we are discussing the topic neonatal jaundice. Neonatal means a child that is less than 1 month old. And jaundice means yellowish discoloration of the skin and mucous membrane due to high levels of bilirubin. And bilirubin is a byproduct of red blood cells. This neonatal jaundice we are talking about becomes evident clinically when the bilirubin levels in the blood are equal to or more than 5 milligram or 80 micromoles. But I want you to know that about 50% of newborn are visibly jaundiced. And these are due to what we call physiologic release of breakdown red blood cells from high hemoglobin in newborn, because newborn, when they're inside the womb, they have high levels of hemoglobin, and this is necessary for the child to survive in utero. But when the child is born, that high levels of hemoglobin is not needed, so it has to be broken down, and bilirubin is a byproduct of this breakdown of hemoglobin. Another reason why 50% of children may have jaundice is due to shortened red blood cell lifespan in newborn. Their red blood cells have a lifespan of 70 days as against 120 days in older children and adults. They also have a visible jaundice because their hepatic bilirubin metabolism in the first few days of life is very less efficient. So because of these reasons, newborn infants are usually, about 50% are prone to have a visible jaundice. What is really the cause of this? That brings us to two types of jaundice. The first one, we call it physiologic jaundice. Physiologic means a normal process that you see in every person, and another one we call pathological. Physiological jaundice does not need any treatment, but then physiologic jaundice is a diagnosis of exclusion. You don't label a child physiologic jaundice. You have to really assess the child for you to make that diagnosis. It's a diagnosis of exclusion. It's also important to know that when jaundice is not treated, it can result to so many problems, disabilities in children, and at times it may lead to death. Most of the children we see that have disabilities, most of them as a result of poorly managed jaundice in newborn. So it's very, very important that we know how to detect it and refer to the next level of care where the child will be treated efficiently. So how do we detect jaundice? Almost everybody can detect jaundice if you pay close attention. You see the white part of the eye, we call it the sclera. When it turns yellow, that is jaundice. There's no way a child will have jaundice without the eye being yellow first. If there's no sclera discoloration, there is no jaundice. Usually starts from the eye, then gets to the face, being yellow. As it progresses in severity, the chest, the abdomen, the lower limbs, then to the sole of the feet becomes yellow. So you see a child looks like banana peel in color. That's the first way, by visual looking at the child. Another one is blanching of the skin. By this I mean pressing the skin, and to blanch this thing, you see yellowish discoloration. So these are the main ways of detecting it, but by and large, it is not as efficient. It's an unreliable method. It's unreliable because especially in dark-skinned people and preterms. So you cannot use a visual inspection and blanching to say, yes, this child has jaundice, or assess the degree of severity of this jaundice. So by and large, you have to take a blood sample to estimate the level of bilirubin. Or else, you do what we call transcutaneous bilirubin estimation. There's an instrument you place on the child's skin, it will give you the level of bilirubin. So these are the ways of detecting a child that has this, detecting the level of, estimating the level of bilirubin in a child's system. So it's important because jaundice is a very serious and an emergency, especially in newborn, because if it's not treated, that child is bound to have what you call cerebral palsy in future. The child may not move, the child may have seizures, the child may have disabilities, may not talk, and so on and so forth. So these are some of the things, and it's important that we and everybody, at least you can detect it. And the earlier it's detected and treated, the better for the child and the parents as well. So these are some of the highlights. But then how do you manage a child that has jaundice? In as much as it's left for the clinician, especially the pediatrician, to assess thoroughly, to manage, but at least we as a community, parents and what have you, have to detect it, because the earlier it's detected, the better. and the management depends on so many factors for you to manage the child. There's a difference between when the jaundice is noticed and when the jaundice developed or started in the child. You can see a child that has maybe it was dictated on the 4th day of life, but it may have been there from birth. So it's very, very important. So that if the caregiver or the mothers or relations are able to detect it as early as possible, it's better for us. A child may have jaundice that may have started on 1st day, 2nd day of life, but because of ignorance, they may not detect it until maybe 7th day of life, 8th day of life, and that is not when it started. It is when it was noted. That's it, this 8th day or 7th day of life. So it's important, and management depends on a lot of factors. And at this note, I want to say that sun exposure is not part of the management of jaundice. Giving phenobarbital is not a way, it's not part of the management. It's better to refer to the expert. We have only 2 major modalities, or even 3. And the management depends on the type of jaundice. If it's physiological, it doesn't need any treatment. If it's pathological, it needs treatment, and treatment depends on the cause of the jaundice. You cannot just tell somebody to go and expose the child to sun. It is not part of the management. You end up damaging the child's brain, because the bilirubin eventually gets to the brain and damages the child's brain, and the child may not walk, may not talk, may have seizures. So please, I'm telling everybody, if you don't know what to do, you mustn't know everything, even as medical personnel. Before you can give advice, try as much as possible to distinguish between the physiological jaundice, which does not require any treatment, from the pathological, which requires treatment. And treatment depends on the cause of the jaundice. It depends on the cause of the jaundice. Don't just let the child go and expose the child to the sun. It is not part of treatment. Giving phenobarbital is not a cause of treatment as well. So, as I said earlier, managing these children with neonatal jaundice depends on so many factors. First, how old is this child when it was discovered? That's number 1. The age of onset of the jaundice. How old was this child when the jaundice was started? Different from when it was noticed. It will give an idea of the severity. Jaundice that began within the first 48 hours of life is a severe form of jaundice. It needs treatment. Jaundice that started maybe 4 days, 5 days later may likely be physiological jaundice, may not require treatment. Also, treatment depends on the level of the bilirubin you have estimated through taking a sample and taking to the lab. And another thing that will determine the type of treatment depends on overall clinical condition of that child. These are the things that will determine whether to treat and not to treat, what modalities of treatment you are going to use. Now, talking about the gestational at the infant's age as one of the factors that determine the treatment. If a child is preterm and you notice the child has jaundice, it's likely to require treatment because of so many factors. They may be prone to sepsis, which may lead to increase in bilirubin level. They are prone to hemolysis, that's the breakdown of their red blood cells. They are prone to less efficient metabolism of bilirubin. So these are the factors that if it's an infant and a preterm. And also, being a dark skin, you may not really estimate visually the degree of severity. So there's a need for you to take a sample before you decide what to treat. That's number 1. The age of onset is an important factor in determining whether to treat the child. As I said earlier, jaundice that was noticed within the first 24 days of life is most likely to be a very severe one. It may have started inside the womb, or what we call utero. And these are possible causes of such jaundice starting on the first 24 day, starting of 24 hours of birth. What we call rhesus disease. In this case, the mother's rhesus factor and the child's rhesus factor are incompatible, leading to what we call formation of antibodies that will destroy the child's red blood cells, leading to high levels of bilirubin. So a child and the mother whose rhesus factor are incompatible, is prone to have a jaundice notice within the first 24 hours of life, this child will need what we call exchange blood transfusion. In this case, the child's blood is removed and replaced with a cross-matched compatible blood either from the father or close relative. Another one is what we call ABO incompatibility. There's a difference between rhesus factor and the blood group compatibility. That's what we call ABO. If the child's blood group and the mother's blood group are incompatible, there's a risk of forming antibodies that also destroy the child's blood, leading to high levels of bilirubin in the blood. So it may see that child having jaundice developing within 24 hours of life. Another thing that may lead to jaundice within first 24 hours of life is what we call glucose 6-phosphate dehydrogenase deficiency. It's an enzyme that is necessary in metabolism of red blood cells. Is deficient most commonly in males. So a child, possibly a male child that has jaundice, notice first 24 hours of life, more likely to be G6PD deficient. It's a severe form of jaundice that we need blood transfusion as well. So the sex of that child or infant is very, very important in assessing the child. Is he a male, is he a female? Now also I forgot to say that in a rhesus factor, you must have taken a history and asked whether this woman has had a child that had jaundice. And also if she had delivered a child that had jaundice, was it male or female? How was it managed? How is the child now? See, these are things you must take into consideration. Or there are other causes like infections. The child contacted while the child was inside the womb. These are the things that can give rise to jaundice noticed within the first 24 hours of life. Now, if this jaundice developed maybe from 48 hours to the first 1 week, it may likely be what we call physiologic jaundice. Remember, we said earlier, there are reasons why the child may have physiologic jaundice. High levels of hemoglobin inside the womb that is not needed again when the child is born. So there has need to break down those red blood cells to normal levels for existence outside the womb. Also, I said earlier, causes of physiologic jaundice. We remember that the lifespan of typical red blood cell is 120 days. But in neonates, in newborn, is less than that, it's about 70 days. So they are easily broken down to form bilirubin that stains the skin yellow. Another reason why they may have this physiologic jaundice, as I said earlier, is because, remember, bilirubin is metabolized in the liver, making it harmless so that it can be secreted either through the urine or through the stool. But newborn, they have less efficient liver enzymes and liver function that may handle excessive red blood cells presented to it. So because of these main three reasons, they are prone to have what we have physiologic jaundice. And in physiologic jaundice, usually, as I say, it does not require any treatment. But you must have excluded other causes of jaundice before you arrive at the conclusion that the jaundice is physiologic. Other things that may lead to jaundice noticed from second day of life include dehydration. A child who is dehydrated, is not fed enough, may also have jaundice. Also, infections can give rise to jaundice noticed after second days of life. Another common cause is when the child has what we call sepal hematoma. In this case, a child that is being delivered, maybe a child had a difficult obstructed labor, the child may have swellings on the head. Usually these swellings develop from a second day of life. And these swellings consist of nothing but blood that has accumulated under the scalp. And they need to be broken down. Remember, they need to be broken down to form bilirubin. And this will give rise to jaundice noticed after the second day of life. So these are the considerations before you decide how to treat. And I said earlier, another thing that will give you an idea of what to treat is the level of bilirubin. These are within the realms of the clinician. If it's up to 15 milligram per dl or more than that to 20 milligram per dl, may require either what you call phototherapy. Phototherapy is a machine that we use to and expose the child. Is a light source that emits a radiance of 450 nanometers. Usually place the child on that so that while the child is under that light, it makes the bilirubin soluble so that it can be excreted in urine or through the stool. But that depends on the level of bilirubin. Or the child may go straight into exchange blood transfusion if it's so high, the level of bilirubin. Or if you suspect that the jaundice may have arisen as a result of infections, then you must give antibiotics, and usually it has to be given through parenteral routes, that is through injections. There's no place for oral antibiotics in this case. Also, what will help you determine the management is on the rate of rise. How is the rise? Usually, if you have facilities, you can do bilirubin estimation maybe every 2 hours or every 1 hour to help you, and then plot a graph to tell you the rate of rise. If it's rising so rapidly, and you predict that in the next 12 or 24 hours it's going to rise to very high levels, then you have to arrange and do what you call exchange blood transfusion. And as you said earlier, it's removing all the child's blood and replacing it with compatible fresh blood. Also, the clinical condition of the child was to tell you what to do. But what we are saying in summary is that please don't give an advice if you don't know what caused this jaundice. If you don't have full details, if you are not in a position to examine this child properly and find out whether this jaundice is physiologic or pathological. And it's not something you can do, oh, the child has to take him or her to the sun. You are doing more harm to that child than good. In the clinic, we have a lot of them that have disabilities, cerebral palsy, hearing problems, and what have you, because of so-called harmless advice by people who don't even know the severity of what they're advising on. So what I'm saying is that please don't give advice on the modalities of treatment. Please also know that every one of us can at least have an idea of what is jaundice, how to detect it, and tell the person it's an emergency. Take the child to the next level of care where the child can be taken care of. That's the best advice you can give to a mother who may be a mother who has just given birth. You don't just oh, it's jaundice, I've given birth to 20 children, so I've an experience. No, it's not so. Even among the medical personnel, there are people who will assess the child and know what to do and do that thing. It will help the child and the child will recover instead of giving advice or something you don't know. Good afternoon, listeners. Today,
Okay, you've heard it all, and I know you now understand, the way it works. You now know how dangerous jaundice is. You don't give advice on what you don't know about, and you don't say because you've had 20 children, you now begin to advise people, or that your grandmother handled it well, that your mother handled it well. It is not like that. So please, let us be careful and always do the needful in terms of health challenges. Don't assume that you know, because you may end up creating more problems. This is where we will end today's edition of the program, Mother and Child Clinic. For questions, please send a voice note or WhatsApp message to 081 250 78553. I take it again, 081 250 78553. And we'll be able to take your questions to the doctors and they will give us answers. If you also want to meet the doctors, we will make arrangements for that to help you get to the root of the issue that is being treated. Remember to indicate your name and location to enable us know where you are coming from or where you are sending the message from. I am Chigozie Chukwuleta saying join us again next week, same time, same station.